I have been struggling to find the words for days now to make this podcast. I had an inkling of an idea a couple of weeks ago for this podcast, and what I wanted to say really is just amplified now by what has transpired over the last few days at the time of this recording. A nurse was killed and immediately villainized before any real information had come out about his murder. And there's so much that I could say about that in regards to the current administration and the gaslighting and blatant lies that are coming out of DHS. But today I really want to focus on nurses, because that's what Alex J. Preddy was. He was a nurse. He was a nurse first because he died doing what nurses do. Seeing the aid needed to be rendered and rushing to someone's aid. And that deserves credence, that deserves honor, and it deserves more than what he was given. I tried really hard to record some short videos for TikTok and socials about this, and I couldn't, because it hits pretty close to home, and I have seen a lot of criticism from the Black community and people of color, and I am not going to say that criticism is not unwarranted, because the criticism is that you didn't care until you saw it was someone like you. But that's a poem, isn't it? First they came for the Jews and I wasn't a Jew, so I didn't speak up. It's the whole poem. You're waiting until you see someone like you. And that is human nature, and that is not to say that that's acceptable or excusable, but it is expected. That has been human nature throughout time immemorial. And I don't say that to diminish the feelings of those who have been targeted for generations. I say it because your anger is valid, but it is not helpful. And I recognize my privilege in saying that as a white woman, as someone who comes from the descendants of people who were marginalized and who were enslaved and who were sent to the other side of the country, and my ancestors did a really good job of blending in or licking boots. And I am not unaware of that. But that's not what I want to address today, because that is for another day. There is a time and a place to address everything, and today I'm speaking to you as a nurse, and everything else can be addressed on a different day. One of the things that has always struck me about nursing, even before I was a nurse, is that it's like a secret mafia. Nurses will tell you that you don't understand nursing until you're a nurse. And as a CNA working alongside nurses, I thought that they were snooty and elitist and exclusionary. And then I got into my last semester of nursing school and then had to take the NCLEX. And then I became a nurse. And I realized that everything that they had said was not anything that I had perceived them as. They weren't elitist or exclusionary. They were elite. And I recognized this as someone who worked alongside them but was not them, and then went through everything that they had to go to become what they were. And I think people really don't understand how grueling nursing school is and what you really have to do to become a nurse. That's part of why nurses are the way that they are. When you get into the field of nursing, it's a little bit comical because nurses are a lot like siblings because the departments interact with each other like siblings interact with each other. The ER hates the ICU and the floor hates the ICU and the ER, and the ICU hates the ER and the floor. Everybody hates each other and judges each other, and don't even get me started on the ancillary departments. Everybody judges each other and thinks that their job is the hardest and they have it the hardest and nobody else works as hard as they do and nobody else knows as much as they do, and they fight with each other like siblings. But just like siblings, they fight with each other. But as soon as someone else picks on one of them, may God have mercy on your soul. And I think about the many times since I've become a nurse that I've seen nurses in the public eye being dogged on by people who were not nurses. Like Alex Wubbles of Utah, who was assaulted and arrested for protecting her patient. The police tried to force her to draw blood on an unconscious patient who could not consent so that they could prove that it was a DUI. And she advocated for her patient, as any good nurse should and would. And the police response to that was to assault her and arrest her because she followed protocol and she respected her patient's rights. And nurses around the country rose up. I think about when Alaska Senator Maureen Walsh publicly stated that the nurses were just sitting around playing cards and they didn't need the staffing or the pay that they were receiving, and how nurses around the country rose up in support of Alaska nurses and mocking Maureen Walsh and staging photo shoots that were granted after hours because they couldn't do it during their work time, because who has time for that, of them playing cards on their shift. I think about Kelly Johnson, a Miss America candidate who was accused by the hosts of The View of reading her emails and going up in her little doctor outfit with her doctor's stethoscope, and how not only nurses but doctors rose up in support of her. Even Redonda Vaught, the Vanderbilt nurse whose medication error ended in a patient's death, nurses around the country rose up in support of her because the hospital was also responsible for the death of that patient and did not suffer any consequences. It was only her. She was a sacrificial lamb and a scapegoat to the hospital's short staffing, to their poor protocols, to their unsafe medication distribution system. She paid the price for the hospital's cut corners, and nurses around the country stepped up for her and spoke out for her. We are siblings, nurses. We fight with each other a lot, and we judge each other a lot. I don't know anyone who will judge a nurse harder than another nurse, but if someone else comes to judge that nurse or to attack them, we all stand up together. Nursing is a sisterhood, brotherhood. We are siblings. And even more than that, beyond the field of nursing, as someone who worked in the emergency department for a big part of my career, it expands beyond the field of nursing, because EMS and cops and firefighters become a part of the family as well. And I remember when Breonna Taylor was shot, thinking about my close interaction with EMS and cops and how closely EMS and cops interact with each other. And my first thought when I heard that she had been shot by a cop was they knew her. And maybe they did and maybe they didn't. She lived in a much bigger city than where I have worked. But that was my first thought. They knew her. And that really is one of the biggest problems with ICE right now is that you have these, quote, law enforcement agents who are barely trained, and that's being generous, coming into cities they don't live in, trying to find the illegals. And all they are doing is creating chaos and violence and hurting the people in the cities where they're going. And I think that people really don't have an understanding of the dynamic of being a nurse, regardless of where you work as a nurse. And that was my original intent for this episode. And so that's what we're going to talk about, because Alex Preddy was an ICU nurse at the VA, and he died protecting a woman who was hurt, which I promise you any nurse who was standing in the street and watched a woman get shoved would have done, because that's what we do. We see someone hurt and we immediately step in. That is an instinct for the majority of us. We see someone needs help and we step in. That is what we are trained to do. To not run away from pain, to not be scared, to step in where others won't. And prior to Alex's murder, this episode was going to be about the nursing strike that's going on in New York. And Alex, being a union member and someone who stood up for what was right and stood up against oppressors, I'm still going to talk about that. Because nurses stick together, and there is a really, really awful thing going on in our country right now. And it permeates everything, and a big part of it is what the nurses in New York are standing up against. So when I was thinking of this episode and I was planning out the topic for it, I kept thinking about Ben-Hur and this line that reoccurs so often in Ben-Hur, which is down Mars, up Eros. And then towards the end of the story, the character changes it to down Eros, up Mars, because he chooses war over love. But this idea of like down with war, up with love is what essentially he was saying. And I was thinking about healthcare in America, which is a joke. Anyone who works in it or has had to experience it will tell you that. But American healthcare is really unique in comparison to the rest of the world in its symbology. American healthcare is the only healthcare in the entire world that uses the caduceus as its symbol. And why is that significant? Everywhere else uses the rod of Asclepius. The rod of Asclepius is a symbol that represents healing. The caduceus, while it is associated with Hermes, and there's a lot that is associated with Hermes and alchemy and such as that, the main thing that the caduceus is associated with in modern times is it was sort of distanced from the god that it was associated with was commerce. And we in America definitely have a profit-based system for healthcare. And so the thing that kept coming up for me as I was thinking of this episode was down the caduceus, up the rod of Asclepius. Because for too long, and it never should have begun this way, ever, our healthcare system has been a system of profit. And I'm going to talk to you today about the realities of the healthcare system from the inside. So this is going to be a little bit long, but I want to give you a view into the world of nursing. Let's pretend you are a patient who is coming into the ER. We're going to say you have abdominal pain. And we're going to pretend that it's like not life-threatening. Okay, so obviously there's a few ways that you can come in to the ER. You can drive yourself, walk in. You can come in by ambulance. Direct admits aren't really much of a thing anymore. At least in my experience with inpatient nursing. Very few doctors will call to the hospital and say, hey, I need to admit a patient. It just really doesn't happen that much anymore. The doctor's offices, if you call your doctor and you say, hey, these are my symptoms, this is what's going on, they're going to say, hey, go to the ER. They're not going to say, hey, let me call and see if I can get you admitted and we can do some tests. They're going to tell you to go to the ER. It just really doesn't happen much anymore with a direct admission. So you're going to go to the ER either by ambulance or somebody driving you there. Regardless of your method of arrival, you're going to be triaged. And what that is there is a nurse who assesses your complaint and the symptoms that you describe and gives you a rating based on everything that you have told her and her assessment of you, or his. I'm saying her, but his or her, their assessment of you. So most hospitals, at least all the ones that I've worked at, use ESI triage system, which is based on both how sick you are and how many resources you're going to utilize. And that's the rating system that's used. So it's a 5-point rating system. An ESI level 5 means you're not using any resources at all. You came here because you needed a prescription refill. And your doctor's office was closed and urgent care was closed and you just need your blood pressure medicine for tonight so that you don't have really high blood pressure and have a stroke before the morning or something like that. ESI 1 means you're dead. They're actively doing CPR on you as you're rolling into the ER. You're going to use as many resources as the ER has available. You're really sick. You're probably going to the ICU if you live. And everything else is kind of in between. And I'm not going to get into the nuances of the other levels, but that's kind of the system. And so the triage nurse is going to assess you, figure out how many resources you need, and that's going to determine where you go, because people don't realize this, but most ERs have levels within them. There are rooms that are for the really sick people, and there are rooms that are for the people who aren't as sick. And a lot of ERs have basically an urgent care within the ER. They call it all kinds of things, fast track. That's the only one that's coming to mind right now. But it's called all kinds of things, but it's basically an urgent care within the ER that is not open for 24 hours. But during the surge times when there's a lot of people coming in, they have an entire section devoted to people who should have gone to urgent care. And that's, that is what it is. So, based on how sick you are, you're going to be assigned to whichever section is most appropriate for your acuity level and how you've been scored by the triage nurse. Now, if you come in and they're actively doing CPR, you're going to bypass the triage nurse, and the nurse who is assigned to you is going to do your triage while she's also, running the code on you or whatever. So not everybody sees the triage nurse. If you come in and you're dead or dying, you're going to bypass that step. But most people who come in through the ER, they're going to be triaged. And someone's going to determine how sick you are. And that scoring is going to determine a lot of what happens next. The people who score higher or technically lower on the score, because 1 and 2 is the really sick score, are going to get more attention faster because they are having a true emergency. Anything below a level 2 is not necessarily an emergency, and nobody likes to hear this, but just because you go to the ER doesn't mean you're having an emergency. You might be sick. I'm not saying you don't need any help or treatment, but just because you're at the ER doesn't mean your situation is emergent. And that is the role of the triage nurse, is determine how emergent your situation is. And the fact that there are 5 levels and 3 of them are not really emergent should tell you a lot about the American healthcare system. So, once the triage nurse has seen you and scored you and done your initial assessment, then, depending on how busy it is, we're just going to say it's not a busy day. You're going to go back to a room. If it is a busy day and you wait in the waiting room for a really long time, then you should consider yourself very lucky, because that means you're not that sick. Because the sickest people get brought back first. It is not a first come, first serve. It's whoever is sickest gets seen first. And if someone comes in who's sicker than you after you, they're going to be seen before you, because it is the emergency room. And what they do is they treat emergencies. And they have an obligation to see and evaluate and treat everyone, and they will, and they do. But they will see the people who are going to die first. So, you go back to the room. Depending on the hospital, a lot of hospitals have protocols in place in the ER where, for example, as we said, let's say you have abdominal pain. Okay, well, we click the abdominal pain order set and put those things in place. You're going to get an IV, we're going to draw blood, you're probably going to get some fluids started, maybe some nausea medicine, maybe not, depending on the hospital. Usually the doctor needs to see you first, or the provider. Sometimes you'll see a PA or a nurse practitioner before they order the medications. But they're going to at least get some things started, an IV. They're probably going to ask you for a urine sample. They're going to draw some blood. They might go ahead and get some imaging orders in to do usually a CT of your abdomen if you're coming in with abdominal pain, so they can rule out appendicitis or a bowel obstruction, things like that are really easy to rule out with imaging like that. And then once the nurse has got that started, depending on where your abdominal pain is, they might also do a cardiac workup on you, like an EKG and things like that, because higher abdominal pain can be a cardiac issue. So they're going to get your vitals, they're going to hook you up to the telemetry machine, and they're going to tell you don't eat or drink anything until the doctor tells you that you can, because anyone who comes in with and abdominal pain is running the risk of having surgery. It might be a bowel obstruction, it might be appendicitis, it might be cholecystitis, which is your gallbladder. There's a high risk of needing surgery with any kind of abdominal pain. Also, if you're having abdominal pain, don't put anything else in there. Don't give your GI system a break. No water, no food, don't. This is a huge problem that I have encountered in my time as an ER nurse is people just always want to eat and drink. As soon as they get to the ER, they're just like, give me some water, give me some ginger ale, give me a turkey sandwich. Yes, I am here for abdominal pain. And it seems, it's like there's this cognitive disconnect with, no, please don't eat or drink anything. You're here because you're vomiting and you're having severe abdominal pain. Let's hold off on putting anything else in there until we figure out what's going on. And people get very angry at you for that. It's almost like clockwork. It's an expected thing. Someone comes in with an abdominal pain, you're gonna get cussed out because you're telling someone they can't eat or drink. So then the provider will see you, the doctor or physician's assistant or nurse practitioner, and they'll ask you about your medical history and how long the symptoms have been going on. They'll ask you specifics about the symptoms, and then whatever testing has not already been done, they're going to order that testing, and that will get taken care of. Now, how fast that gets taken care of is very dependent on how busy the ER is and the rest of the hospital, depending on the testing that they're ordering. If you're coming in the evening, or at night, an ultrasound or MRI or CT is going to take a long time because they're running on a skeleton crew. Those departments are typically not staffed as heavily at night as they are during the day, and so it's going to take a while. And once all of the testing is done, let's say they've decided, okay, you probably need surgery, but you don't need surgery tonight, or maybe we can give you IV antibiotics. We're going to say you have appendicitis, but it's not like get her to surgery right now, appendicitis. So they're going to admit you. Okay, so the hospitalist is going to be the one who admits you most likely in that scenario if they're not calling in the surgeon to come see you to do this surgery. If they do call in the surgeon to do the surgeon will be the one who admits you, and they'll come see you and they'll talk to you about the surgery and they'll get your consent, and then you'll be wheeled off surgery and then you'll spend the night in the hospital. Let's say they've decided it can wait till the morning, but you're definitely going to need surgery. So then the hospitalist will admit you. That's going to take a while, in my experience. The hospitalist will review your chart, and then they'll come and they'll talk to you and they'll ask you everything that they already reviewed in your chart and get your entire medical history and your entire medication list, and they'll ask you a whole bunch of questions, and then they'll tell you, okay, we're going to get you admitted, and you'll think it's going to happen right away. It's not, because they have to type up their entire note before you get admitted and put in all of the orders for you to be admitted. And not just in order for you to get admitted to the floor, like everything, like the diet that they want you to have, even if that's like don't eat anything, and all of the medications that they want you to have, including the ones that are as needed, like pain and nausea medicines and things like that. That takes usually about an hour at a minimum. And that's just assuming that you're the only patient they're admitting, that they don't have anybody else to see. And so once they put that in, then something called the bed board has to look at that. And the bed board is this very like ethereal being that no one actually really ever interacts with much. They just are at the mercy of. And the bed board assigns beds to patients and tells people, no, you cannot have beds, and reassigns beds. And it's all very mystical and mysterious. So once the order is in for you to be admitted, then the bed board will assign you to a room. And once the bed board assigns you a room, in most hospital systems now where they're using electronic medical records, it'll pop up on a screen where all the ER patients are visible. And usually the charge nurse of the ER will say, hey, your patient got a bed. They're assigned to room 303. And then you call up to the third floor and you say, hey, I'm calling to give a report on this patient that's going to room 303. And the floor usually says, hey, that nurse is doing her med pass right now. She can't talk to you. Can you call back in like 30 minutes? And you say, okay, I'll call back in 30 minutes. You call back in 30 minutes and they tell you she's gone on her lunch break. And you ask if somebody else can take report because it's been 30 minutes now and you need to get this patient up to their room. They give you a lot of attitude and they say, we'll see if we can get her back early. Call back in 15 minutes. And so you call back in 15 minutes and the nurse who is taking your patient is really angry at you for interrupting her lunch break and cutting it short. And she asks you a whole lot of questions that are not pertinent to an ER assessment, and she's really mad that you don't know the answers, and she has not reviewed the chart at all. Then you say, okay, I'll be up in about 15 minutes, and they say, can you wait like an hour, because we just had another admission up here. And you say, And the charge nurse is staring at you as you're having this phone conversation. Say, don't let them make you delay this. And you say, well, my charge nurse is telling me I cannot delay. We need to clear this room out. We've been waiting for a while. And they go, fine, go ahead and bring them up. And so you bring the patient up, and everyone is angry at you for bringing up the patient to the room that was empty, that I guess was a surprise to get an assignment for. The patient is really upset with you as you're bringing them up because it took so long for them to get a bed, and they're very tired because it's like 1 o'clock in the morning at this point, and they're like, I wish I could have got up to this room sooner. And you're like, boy, me too. And then you get put in your bed in your room, and you're ready to settle down for the night. And then your nurse, who's going to be taking care of you for the night, needs to do her admission assessment. That has to be done within like 1 or 2 hours of you getting into the room, depending on the hospital policy. And so she has to ask you a ton of questions that you have already answered in the ER, and you are really frustrated because you've already answered all these questions and it should already be in your chart. And she's really frustrated also because you already answered these questions in the ER and it should totally be in your chart. But for some reason, she has to ask you these questions again, and she will get in trouble if she does not ask you these questions, and she will get in trouble if she does not ask you these questions shortly after you arriving onto the floor, and go over all these things with you, like making sure you wear your grippy socks and making sure you put your call light and why we put bed rails up and not getting up without assistance and things like that. And so the rest of everything, just progresses as it does, as slowly and as methodically as that goes. But let's jump to when you're ready to discharge. So you had your surgery, you've recovered nicely, you're feeling great. The doctor decides that you're ready for discharge, and he comes in and he talks to you and he says, okay, we're going to get you discharged. And you think, let me pack my bags, I'm ready to go. No, because the doctor is going to finish his rounds, however long those take, on that floor at the very least. And then he's going to write your discharge paperwork up. And some doctors will complete their entire rounds before they write up discharge paperwork for the whole hospital. I have seen it happen. So then after he has finally finished his rounds and starts writing up your discharge paperwork, then he gives information to case management for whatever you might need to go home, whether maybe you need a walker or oxygen or some medication sent to the pharmacy or insurance help or whatever. And they're going to work on that for you. And then the nurse is going to get the information about your discharge. And they have to print out your discharge paperwork, and then they have to go over it with you and make sure that you have a ride to go home. And if you have somebody there with you, that's great. If you don't, that's more complicated. Then she's got to figure out your ride for going home. I say all of this because I don't think most people realize what goes on behind the scenes when they go to a hospital. And I don't think that most people realize how much work is being done that they don't see. And I say this because I hear so many people talking about nurses being greedy when they strike, and they don't realize that striking is almost never about pay. Pay is just one aspect that gets discussed and gets brought to the table. The majority of it is about staffing ratios. It's about safe working conditions, because if your nurse has 8 patients and your doctor writes your discharge papers at 8 a.m., it might be noon before she can ever even look at those discharge papers. And that's just discharge papers. And discharge papers are not a matter of life or death. But you know what is? Lab work and imaging, x-rays, CT scans, MRIs, things like that, medications. And so if she can't get to a chart for hours to see discharge papers, what do you think is going on if he writes orders for a new med or some more lab work or another scan? And I have seen people die because of the difference of a few hours. I've seen people die because of the difference of a few minutes. And to make the assumption that nurses striking are just doing so because they're greedy is to fundamentally misunderstand what it is to be a nurse. I am proud of a lot of things that I am, and I am proud of a lot of things that I've done, but I am not proud of anything more than I am to be proud to be a nurse. It is one of my greatest achievements, and it is one of my greatest honors to be able to be someone who is there for people at their most vulnerable, to advocate for people who cannot advocate for themselves, to care for people who cannot care for themselves and who no one else can either. It is one of the most precious things that I have ever had the privilege to do in my entire life. And when I see people saying things like they're just greedy, it disgusts me that you would disparage people who sacrifice so much to be there for you, to diminish them to nothing more than greedy, when what they are actually doing is fighting for you. I remember my last semester of nursing school, there was a guy in my class who was a little right-wing leaning, and for some reason had it in his mind that he was going to challenge one of our instructors, because one of our instructors had said something along the lines of most nurses lean left and most doctors lean right politically. That's just the statistics. And he challenged her on that. Are you saying nurses are all Democrats? And she said, no, I didn't say anything about parties. And she said, I said most nurses tend to lean left. Look at what nurses do. They are advocates for the public, and that tends to lean towards a more liberal mindset. That's all I was saying. And for some reason that has stuck in my mind forever. And it's funny because I was very conservative when I started nursing school, and the longer I have worked as a nurse, the more liberal I have become. Because it is very true that when you are advocating for the public, you become a lot more liberal. And most people who I know who are very conservative have had very little interaction with the public. And to go back and address the staffing ratios, there's one thing that I really want to address because it is becoming increasingly an issue with the nursing shortage becoming worse and worse, is boarding in the ER. And most people have no idea what that means, but that is when you go into the ER and they decide you need to be admitted and there are no beds for you. And while there might be a room with a bed, the staffing ratio would be so dangerous that they can't send you up there. And so what they do instead is they keep you in the ER and you're admitted as a patient. And there's an ER nurse taking care of you who has all of her other emergent patients to take care of. So she has to be a floor nurse and an ER nurse at the same time. And sometimes you're in a hallway. If you're lucky, you're in a private room off to yourself. But it is something that is becoming a bigger and bigger problem across the country. And it is because of unsafe staffing and poor working conditions, because no one wants to work med-surg nursing. And I worked med-surg right out of nursing school. And I know why no one wants to work med-surg nursing, because they increase your ratios and think that it's fine. They don't pay you any incentive. They don't call in extra help. You just have to take extra patients and do the same amount of work, extra work really, the same amount of work per patient, with no extra help, no extra compensation, and you're the one who is in trouble, and your license is the one that's on the line if anything goes wrong. So, just as an example, the floor that I worked in right out of nursing school, it was on day shift a 4-to-1 ratio, so each nurse had 4 patients, and on night shift it was a 5-to-1 ratio, but we routinely got flexed up to 6-to-1, and there was more than once that we got flexed up to 7-to-1. And I remember one night that I had a patient who was on a drip, an IV drip, that the protocol mandated was a 4-to-1 ratio. You could not have more than 4 patients if you were taking care of a patient that was on that drip, because their monitoring needed to be so closely monitored. You didn't need more patients than that. We had some empty rooms, and my charge nurse came to me and said, "Hey, you're getting another patient." I said, "Absolutely not. I have this drip. I cannot take another patient. This is a 4-to-1 ratio." He said, "You'll be fine." I said, "No, I won't. This is unsafe. Absolutely not." And I did everything that I could to refuse that patient and refuse the assignment. And he assigned that patient to me anyway, and there was no one to take care of the patient. Being as new as I was, I didn't know who to call or who to go to for help, because, it's always your charge nurse that you go to for help. And he was the one who was screwing me over and screwing the patients over. In hindsight, I would have called house supervisor and potentially would have called the manager, because she would have taken my call and she would have advocated for me. But I had 5 patients when I should have only had 4 because of the drip that I had on one of my patients. And that patient was just unsafe because the charge nurse wouldn't take the patient. He wanted to give it to me instead. This is the reality of what unsafe staffing is. That situation turned out okay. Thank God. But I have known plenty of people who did not have as good of an outcome, who did not have their patient turn out okay, who, because they were pushed past their limits, were not able to monitor their patient as closely, and the patient had bad outcomes. And the nurse always gets blamed for it. Not the charge nurse who made the assignment, not the bed board who made the ratios unsafe, not the hospital who did not safely staff. It's always the nurse. The reality is that the American healthcare system is abusive, and it's not just abusive to patients, it's abusive to the people who work in it. I think that looking at private health insurance is just the epitome of everything that is wrong with our system. Not that it's the only thing that's wrong, but it's just the embodiment of the whole problematic system. Looking at private insurance and corporations and the way that healthcare is run, just as an example, I've talked in some recent episodes about losing my job. I worked for a home health agency that was owned by an insurance company. And that, in my opinion, should be illegal, because the insurance company also paid the agency for its patients that were seen by the agency. So basically the insurance company was paying itself because it owned the home health agency. There is so much that is just insidious about private health insurance and what they do and the rates that they negotiate. I remember before the Affordable Care Act was passed, aging out from being on my father's insurance that he got through work. And there was a period of time that I was uninsured, and I had to go in the hospital during that time. And I had, several doctor's appointments, and finding out how much the rate was that was charged if you were self-pay versus what they charged insurances, and seeing how much the markup was from hospitals or doctor's offices or whatever. And then I found out that they mark it up that much to cover for the insurance companies that just don't pay as well. That gets into a problem with people who are uninsured and the care they're able to receive, because every urgent care that I've been to in the last probably 10 years, they've demanded payment up front. And it's not even like a run your insurance and here's your copay. It's here's what we charge. We'll give you a refund if your insurance covers more than that. And so if you don't have $100 to put down, you just don't get care. And I hear so many people talking about the abuse of the ER. And the abuse of the ER is because of the insurance system and things like urgent cares demanding payment up front. The ER, you can go in and they will determine if you have an emergency or not, and they will treat you and they can send you a bill. Urgent care won't do that. They don't have laws where they have to assess you and make sure that you're not having an emergency like the ER does. The ER has EMTALA, which is a law that was, I believe it was passed in the 90s. But it says that you have to assess anyone who comes into the ER, make sure that they are not having an actual medical emergency, or if they are, treat them for that medical emergency. And you can't kick them out of your ER. You cannot transfer them to another facility until you have determined whether or not they have a medical emergency, and if they are, you have stabilized them. Urgent care doesn't have that or anything like that, and so they can charge up front. And so people come to the ER who really don't need to come to the ER because they can't go to urgent care, because they can't afford to go to urgent care. And so when I hear people talk about the abuse of the system of the ER, my first thought is, who is really the abuser? Because people need health care. People need to be able to be seen by a doctor. And in this current economy, I would say the majority of people, and I don't think that's making a large stretch, don't have money to put down up front for emergencies or urgent needs. They can pay on it, but they don't have the money up front. And urgent care does not allow for that. So who's really the abuser? Is it the person going to the ER, or is it the system that does not allow them to get health care unless they go to the ER? And I think we see this a lot in health care, with people being blamed for a system that has set them up for failure. I mean, we look at the opioid crisis. The opioid crisis started because CMS, the Center for Medicare and Medicaid Services, decided that pain was a vital sign. And in deciding that pain was a vital sign, they insisted that doctors treat pain as a vital sign. Now, if you're not familiar with what vital signs are, it's temperature, pulse, respirations, blood pressure, and often your oxygen saturation level. These have to be treated if they are outside of normal limits as part of standard practice. If you see something that is outside of normal limits and you do not treat it, it is considered malpractice. It is considered neglect. And so when they decided that pain was a vital sign, and they also decided that pain is whatever the patient reports it to be, they also gave criteria for how each level of pain should be treated. And anything that is severe pain should be treated with narcotics. And that is anything that's like 7 or above. And so people walked in to doctor's office with absolutely nothing wrong with them physically and said, my pain is 10 of 10 every day, all the time. And so, because CMS had told doctors what their protocol was for that, they prescribed them narcotics, a whole lot of narcotics. And people started selling them on the street because they didn't really need them, but they could sure use the money. And then suddenly, there is an opioid crisis, and it's doctors' fault. And then they started fining doctors if they overprescribed narcotics. And now, the people who really need them, who do have chronic severe pain, have a very difficult time getting them, or are treated as if they are drug addicts, because the system is abusive, both to those who work in it and those who need it. And so much of what I hear and what I see being talked about is just distraction propaganda. Just look over here, look at the birdie, look at this thing going on over here, instead of focusing on what the problem is. And the problem is that healthcare should never be a for-profit industry. And that does not mean that people who work in it should not make a living. In fact, it means the opposite of that, because, boy, the current system really likes to not pay the people who work in it a livable wage now. It means that people should not be profiting off of other people's suffering. For-profit and healthcare should never be in the same sentence together. And they have gaslit us so much that we're afraid to speak up for ourselves and our patients. I mentioned earlier in the podcast that we fight with each other like siblings, and I think so much about me and my sisters. When we were all living at home is a term that I use very loosely, with my parents, and that we were all scared to say how we really felt or what we really thought about what was going on, because we were all afraid of the retaliation. We were all afraid of being in trouble, and we were all afraid that if we said it out loud to each other, that the others might tell on us. And that is the situation with the American healthcare system. That is the situation with nurses. I've mentioned it in podcasts before that I tried to unionize a hospital, not the last hospital I worked at, but one of the hospitals that I worked at. And every single nurse that I talked to was for unionizing the hospital, except for one nurse. There was literally just one. But every single one of them were afraid. They were too afraid to lose their jobs, and so they wouldn't do it. This was a really long and really weird episode for me, but I hope that it was enlightening for you. I hope that it gave you some insight into things you might not have known before, and I hope it gives you an appreciation for not just nurses, but healthcare workers in general. I hope that it will inspire you to, like Alex Preddy, to be a helper and to step up where others will not. Thank you all for listening, always, and I hope you'll join me next week on the podcast as we both continue to work on our Mosaic in Progress. Please check out all the links at linktree.com/Mosaic in Progress. Follow me wherever you follow people, and I will talk to you all next week.